Hemodynamic Pathways of Gestational Hypertension and Preeclampsia by Wilfried Geeslaers. This review summarizes published observations on maternal hemodynamic changes from first to third trimester in women who eventually develop gestational hypertension, early onset preeclampsia, or late onset preeclampsia. Clinical symptoms of gestational hypertension and preeclampsia occur in the second half of pregnancy. However, evidence is clear that they relate to pathophysiologic events in the earliest stages of pregnancy and are associated with a gradual expansion of body water volumes with advancing gestation. According to the new definition by the American College of Cardiology, the American Heart Association, and other international societies, the threshold to discriminate normotension from hypertension is set now at 130 over 80 mm mercury. As blood pressure relates to a balance between vascular resistance and intravascular volume flow, hypertension by definition is a spectrum varying between increased vascular resistance or raised intravascular volume. Current research on maternal hemodynamics mainly focuses on the heart and the arterial system, but seem to overlook a large and important part of the circulation, the venous system. Next to this, another poorly explored aspect of circulatory physiology is the distribution of the total blood volume, of which only 1/3 is in the arterial system, 1/3 circulates as venous return, and 1/3 resides in the venous capacitance bed, located mainly in the splanchnic veins and the liver. This volume serves as a spare blood volume to be mobilized into the circulation when increase of cardiac output is needed. The combined assessment of all major components of the maternal circulation is feasible using non-invasive technologies such as Doppler sonography to evaluate venous blood flow in the liver and kidneys and arterial flow in the uterine arteries, in addition to impedance cardiography to measure cardiac, central arterial and peripheral arterial function, and bioimpedance spectrum analysis to estimate body water volumes. This approach also allows for exploring the interdependency of different components, particularly in conditions of cardiovascular stress such as pregnancy. Combining the results of our studies with data reported already since the end of the last century allows identifying two types of gestational hypertension. Type 1 relates to increased cardiovascular resistance in women with normal cardiac output. The opposite is true for type 2, where high cardiac output is associated with normal to low vascular resistance. Venous hemodynamic dysfunction, as determined by increased venous Doppler impedance index, is not a feature of gestational hypertension. Early onset preeclampsia presents with increased vascular resistance from the first trimester onward. This is associated with low cardiac output, but also with high total body water volume and venous hemodynamic dysfunction from the second trimester onward. The latter can explain the clinical symptoms of preeclampsia via the processes of organ congestion and associated capillary dysfunction. As such, gestational hypertension can be considered a disorder presenting with abnormal functioning of the heart and arterial system, similar to preeclampsia, which however shows superimposed venous hemodynamic dysfunction. Late onset preeclampsia also presents in two types. Type 1 shows high maternal cardiac output with normal to low vascular resistance throughout all stages of pregnancy. Type 2 also starts with high cardiac output, but shows an abrupt crossover to a high resistance circulation in the third trimester. Both types show venous hemodynamic dysfunction in the third trimester. Maternal vascular maladaptation can result from abnormal inflammation signals by the conceptus and/or the mother during the placentation process. Here, placental growth factor, vascular endothelial growth factor, and many other vasoactive mediators are involved. This process is enhanced by pre-existing maternal conditions such as immune disorders, cardiovascular dysfunctions, or diseases from other organs. Body water volume expansion in a maladapted vascular system results in oxidative stress, systemic inflammatory response, and endothelial activation, not only at the level of the arteries, but also in the veins and the microcirculation. This process of venous congestion is known to induce hypertension and capillary leakage. This pathway can explain the development of early-onset preeclampsia. Intravascular volume overload can trigger activation of the endothelium via shear stress, a process enhanced by pre-existing maternal cardiovascular dysfunction and gestational rise of intra-abdominal pressure. Again, oxidative stress, systemic inflammatory response occur, clinically presenting as hypertension and capillary leakage with venous congestion in late-onset preeclampsia type 2. High intra-abdominal pressure in itself can produce venous congestion via external compression of veins, and this does not necessarily involve oxidative stress or systemic inflammation. This figure integrates the theoretical pathophysiologic pathways of preeclampsia, bringing up the interesting unifying hypothesis of venous congestion as the common mechanism explaining clinical symptoms of preeclampsia at every stage of pregnancy. As such, the type of gestational hypertensive disorder presenting in the third trimester after installation of volume expansion relates to the type of cardiovascular dysfunctions already present in the first trimester. The information on venous hemodynamics and body water volume homeostasis allows for better understanding the background mechanisms of gestational hypertensive disorders, offering perspectives to guide clinical management. However, confirmation of more in-depth clinical and experimental research is needed.